Okay. Welcome everybody to the Health and Wellbeing Board, the Dorset Health and Wellbeing Board on the 30th of March. I will just move on to the first item on the agenda today, which is to receive any apologies. Do we have any apologies, George?
Vivian Broadhurst, Chair.
Yes, we do.
Thank
We've got
you.
apologies from Vivian Broadhurst, Teresa Levy, Nicholas Johnson and Scott Chilton.
Okay, thank you. And just so the public are aware, we also have quite a number of people who aren't actually members of the board, but add really valuable contributions and questions, which, depending on time, I do allow that interaction. So if you are not a member of the board, therefore not on an official list, please say who you are if you put your hand up and want to speak on an item. Thank you. Hands up is good because we're quite a few, so photos, all your pictures aren't going to be showing. So hands up on the bar if you can, please. If you are having trouble with that, then of course switch on your camera and wave. You will notice that the Dorset Health and Wellbeing Board is continuing to take place as a virtual meeting. The majority of those members of the board wish us to have that option as a facility going forward, because it does mean more people can attend. But just in case decisions are made, I need to advise members that you are advised that if any decision is required, the appropriate corporate director would be the responsible individual to make the final decision, whilst considering the views expressed by the wider committee membership. Right, I'll now move on to declarations of interest. I haven't got any hands up for declarations, so I'll move on to the next item of the agenda, which is public participation. I'm advised that there are no members of the public who wish to take part. The next item on the agenda is councillor questions, and no councillor questions have been received. So we move to item number 5, which is the local outbreak management plan, which the Director of Public Health, Sam Crowe, will now deliver to us. Thank you.
Thank you. Thank you very much, Chair. So if you bear with me, I'm just going to share my screen and walk you through the current situation. I've just got a few slides that I think the board would find helpful, so hopefully you should be able to see that coming through in full screen now. So I'll start with the current situation. Probably you're all aware that we are in the middle of a second peak of Omicron. So if you look at this epidemiology chart, you can see that in early January, we had the first peak related to Omicron BA1 infection. Cases started to fall away. When we started to loosen some of the regulations, we saw another little bit of an upturn in infection rates in February. And then cases fell consistently across not only Dorset Council, but our neighbouring councils. But you can see since the end of the first week in March, we're now being hit by this second subvariant of Omicron called BA2, and that's leading to a new local peak with much higher infection rates, particularly in the Dorset Council area. So at the moment, we're seeing rates well over 1,300 cases per 100,000. The Southwest is at a similar level, and England lagging behind at about 890 cases per 100,000. I think England is only lagging behind because Dorset and other areas in the Southwest have perhaps had less infection overall in previous waves. So the sort of background immunity is perhaps lower, and therefore it's a bit easier for Omicron BA2 to spread at the moment. But the big difference now, compared with previous weeks, of course, is the impact of vaccination, and that protection afforded by vaccination is still very, very effective. So even though we've seen hospital occupancy rise quite significantly in the past 2 or 3 weeks, we're currently at 254 people in the Dorset system. Far fewer people are in hospital directly as a result of COVID-19. It's a mixture of people who've been admitted because of COVID, but also people testing positive while they're in hospital, particularly because length of stay is fairly long at the moment. And if you look at the number of people requiring oxygen support, you can see very clearly that the way that the infection is affecting people is far less severe than in previous waves. So far fewer people needing oxygen support, which is really, really good news. So I'll move on to talking about living with COVID, which is the government strategy. This was announced on the 21st of February. We did have late last night further guidance, particularly in relation to the people in the population who will still be able to receive access to free testing. But as I'm sure you're all aware, the first announcement on the strategy in February heralded the end of all of the legal requirements, including the legal requirement to self-isolate. The regulations were lifted. It meant the end of contact tracing as we know it, and the strategy set a date of the 1st of April for ending universal access to free PCR and lateral flow testing. And overall, the strategy was talking about a focus which is shifting to protecting the most vulnerable, and particularly those who are being cared for in higher risk settings. So yesterday, March the 29th, we had further detail. Health Secretary made an announcement which confirmed that selected groups will still be able to access testing, and that will include patient-facing frontline employees, people working in adult care settings, including home care and care homes, and a range of other high-risk settings, including prisons, supported living accommodation, residential care for children with significant educational needs and disabilities. PCR testing for people who are symptomatic will remain for people at risk of serious illness due to COVID, particularly if you're thinking about the need to access some of the new therapeutic treatments for COVID-19. So that testing will be provided by the NHS, and NHS and adult social care staff will still be able to access testing. From the 1st of April, there's a move to general advice to stay home if you're feeling unwell. So anyone who thinks that they may have respiratory symptoms, which could be COVID-19, instead of seeking a test, you'll be advised to just stay home until you feel well enough to return to your normal activities. But anyone testing positive for COVID-19 after the 1st of April, so you've actually had a test, perhaps in relation to your role, will be advised to stay home for 5 days, and that's the main infectious period. So the public health advice remains, don't go out and spread it about. Even if you can't get tested, if you think you've got COVID-19, we are still urging the public to take precautions, avoid mixing with people, and just try to keep at home until you feel better. So just a couple more notes on what this will mean locally. The public health team will continue to offer a day response team to support higher risk settings in managing their outbreaks, but the guidance has been very clear that we are shifting towards a more general approach to health protection. So the degree of support that we've offered previously probably won't be able to be provided. We'll provide more general advice on supporting settings with completing risk assessments, for example, as we move towards a more general approach to health protection. There's further national guidance which is coming out. Much of it won't land until the 1st of April, so our commitment locally is to continue to review that, working with local partners, and we'll continue to advise of any significant changes. The targeted community testing programme, which provided access to lateral flow testing for key groups in the community, ends on the 31st of March. We are going to continue to have a limited supply of lateral flow tests, which will be held to support local outbreak management and also people who may not be able to access testing, but are still visiting those high risk settings. The contact tracing teams, which did an amazing job under both councils, wound up their business after the end of the data flows. So as national test and trace was wound down around about the 28th of February, those teams have also been thinking through how they could be redeployed to support other areas of business. And the other issue I need to make the board aware of is that the Health Protection Board will now cease following a debrief, and responsibility for COVID-19 will move to the new Health Protection Network. So when COVID started, we stood down the Health Protection Network, which was a system-wide group which met on a regular basis just to consider a number of health protection issues and also to provide assurance that we were able to respond to significant outbreaks. that work will now continue under the Health Protection Network, but it will be wider than just COVID-19. So it'll also consider our medium-term response to other issues like TB, flu planning, for example, and a range of other infections. The local outbreak engagement boards, which are a subcommittee of both health and wellbeing boards, we've agreed to stand down. So because of the move to general messaging and the lifting of regulations, there's now less of a role for local authority outbreak management plans. And because the messaging is so general, we've decided that there is now less value in continuing to run a local outbreak engagement board. So they are stood down for the time being. Of course, if the situation changes, then we would consider standing them back up again. But at this moment in time, we don't consider this necessary. And then just a final note on the vaccination programme. I think this chart summarises the situation quite well. On the left, you can see the breakdown of vaccination coverage for everyone aged over 12 for England. And then on the right-hand side, that provides a comparison with the current situation in Dorset. And you can see there's quite a difference in the proportion of the population who've had at least one dose, 74% in Dorset, as opposed to 66% in England. And then you can see the breakdown of some of the other proportions, all the way down to just 7% of people over the age of 12 in Dorset who've had no dose of vaccine at all, compared with 10% for England. So Dorset's got a really, really high level of protection from vaccination, testament really to all of the hard work that people from right across the system put into delivering that extraordinary effort. And just to say that at the moment, the focus is on delivering the 4th booster. So over 75s and clinically vulnerable are able to come forward for a 4th booster dose from March the 21st. And they're also calling children who are clinically vulnerable aged between 5 and 11. The focus locally is now on understanding how best to shift to a business as usual model of vaccination. So there's some thinking going on about how to sustain this away from those big emergency high volume rollouts that we've seen in past waves. And then just a final note, we're continuing to use our Trusted Voices networks and our vaccine ambassadors, which are continuing in the work with communities where we've had slightly lower uptake, and they'll continue to be working to deliver impartial information and to try to improve uptake in those groups yet to receive the full complement of vaccination. So that's my summary of where we are. It obviously is a bit bumpy at the moment. We are going to have to bear with the impact of this current infection wave. Looking at the modelling that the Epicell has been doing over the past few weeks, we think that the peak in hospital admissions is likely to come in the first 2 weeks in April. And it's quite likely that we'll see the infection rate start to fall through April and May. At some point, we'll reach a point in the population where either we have enough people vaccinated or immunity from previous infection means that the virus will find it much, much hard to pass through the population. And at that point, we'll start to see cases fall. So I'm happy to pause and take questions, Chair.
Thanks very much, Sam. That was a really good summary. It's a shame that the engagement programme has to shift a bit, because I thought we were doing really well on that, but I understand resources and we need to go with guidelines. But of course, you'll let us know if we need to step up again. We seem to be quite good at forming at those meetings at short notice. Are there any questions for Sam on the local outbreak management plan? I see one hand up there. See who that is. Sorry, Martin Longley.
Yeah.
Hi there.
Thanks, Chair. Sam, I appreciate you're the messenger, and you said it's a bit bumpy at the moment in primary and social care. I think it's not bumpy, it's incredibly rough. We've got an enormous number of staff off. I think 11% at the moment are off sick with COVID, and that's causing huge impacts. From 2 years ago, banging frying pans, we feel like we've been chucked into it now, and the heat's been turned up, I think. Do you know, can you assure us now that the necessity for patients to be tested negative on leaving hospital to be admitted to care homes is going to be dropped as well? Or do we know if that's still going to continue? Are care homes still going to insist upon negative COVID tests to accept patients?
Yeah, it's a really good question, Martin. I think from scanning the briefing that came out late last night, from memory, it did say that they would maintain testing on discharge. So before admission to a care home, you would need to test negatively. But of course, when the detailed guidance comes out, we will look at that very carefully. One of the changes affecting care home settings that I haven't covered today is that they are looking to reduce the period where the home would be effectively in suspension from 14 to 10 days if there's evidence of an active outbreak. So there'll be further guidance coming out about adult social care, and I suspect also around the flow and discharge of patients.
Sounds all right, Martin.
Yes, fine, thank you.
Okay. Patricia Miller. Hi there, Patricia.
Hi, thank you. Just a couple of points. We, in anticipation of the new NHS guidelines coming out, Tim and I have asked all the NHS providers to try and take a consistent approach to the guidelines, because I know we've got some variation which is not helping, particularly when we look at visitation. But also just to make the board aware that whilst the numbers of admissions at the moment are low compared to the January peak that we had in the second or third wave, because we've got high numbers of patients that are in hospital that really should have been discharged some time ago, it's putting an extraordinary amount of pressure on the secondary care and community system, and not just because of the increase in number of patients that are COVID positive, but also because of the number of staff absences relating to COVID. And we are incredibly concerned about the fact that hospitals will really struggle to cope when the peak hits, because the peak will be there for several weeks. And so similar issues in primary care where we've got staff absence that are leading to gaps in rotas and service. So it's just for the board to be aware of that is having ramifications everywhere.
Thanks, Patricia. And if you've got anything that you think board members can do to assist, please put that in the chat or email us all via George Dare, who looks after the board, if there's anything in particular you feel that we can help with. Forbes. Hi
Yeah,
there.
thank you, and thank you for your report, Sam, and absolutely fully support the comments already made by Martin and Patricia. It was just really to complement that the longer COVID goes on and the more patients we have suffering from COVID, the greater it impacts on our ability to deliver care to all the people who don't have COVID. So that every time we get a COVID peak, and we're certainly experiencing that significant bump as described at the moment, then it delays our ability to care in other ways, and therefore that it increases the risk in terms of health outcomes that we have in our system, and that is equally concerning to managing COVID.
Yeah, thanks, Forbes. That's a really good message, which somehow we need to deliver to comms. I don't know, Sam, if that is sort of the take extra care even though you don't have to message.
I think it's a very helpful message to remind the public that even if you're comfortable with your own level of risk, just to keep thinking through the implications of having this infection at such a high level in our local system. And certainly I've done that in media briefings over the past couple of weeks. This wave is all about disruption on local services. It is true that we're shifting to a different strategy because of the protection afforded by vaccination, but looking at the staff absences, I think it's 672 according to the COVID dashboard today, which is we haven't seen numbers as high as that for quite a long time. So it is going to cause significant disruption, and I posted it in the sidebar there for people who can't see it. Nationally, some of the mortality due to non-COVID conditions is a far bigger worry in public health terms to the Chief Medical Officer than mortality due to COVID. And that's partly because of the pressures that we've seen all the way through the pandemic, including some delays to treatment. So it's a really difficult balancing act at the moment, but we do have to find a way out. Just for the board's assurance, there are no variants of concern at the moment circulating other than BA1 and BA2, so there's nothing further significantly likely to affect the population at the moment. And in terms of the monitoring of mortality nationally as well, although we've seen an increase in hospital admissions, that's not converting through into rises or increases in mortality due to COVID. So from a sort of public health and epidemiological perspective, there aren't any red flags. It's just that we're going to have a significant period of adjustment while we get used to this. And the current wave has just come at a really, really unfortunate time when we've lifted a lot of the regulations and we're transitioning to a very different way of living with the virus, but it is causing significant impact at the moment.
Thanks very much, Sam. Very, very difficult situation everybody's in, but as I said to Patricia, if anyone thinks there's other things that we can help with as a board, then please get in touch with George or me and we can email around. Right, Sam, I'm now going to move on to number 6, which is the pharmaceutical needs assessment. Jane, you're there? Hi there.
Hi, yeah, so I was just asked to give a verbal update on where the pharmaceutical needs assessment has got to. So we've obviously been working with our virtual steering group, and that includes members from the local pharmaceutical committee, medicines management and primary care at the CCG and NHS England. And we're also linking in with primary care network clinical directors to kind of understand their perspectives on the P&A. We've done some initial engagement with the public about how they use community pharmacies, and we've had that's just closed down. We've had over 1,000 responses to that. Most of the people responding predominantly white British, predominantly female, predominantly over 60 and taking prescribed medicines. So possibly not a fully representative view, and we're still analysing the themes that are coming out of that. But most people are going to pharmacies in person and collecting their prescriptions. Most people attending the same pharmacy rather than changing about which pharmacy they use, and mostly choosing their pharmacy because of where it is in terms of closeness to their home. Although a quarter of people not using their closest pharmacy, so a little bit to understand about that. And of course, the people that have responded that are younger do seem to have a different a way of using their pharmacies, so we need to understand that as well. We've nearly got through the data collation phase, so that's nearly all complete, and we should be on track to go out to formal consultation in May. It could slip into early June. Obviously, we've got the delegated authority from the meeting in September to enable us to work to that timescale, and we will be bringing the consultation draft to the meeting in June so that people can have some input into it at that point. And regardless of whether we do have a slight slip in the timescale on that consultation, we should be on track for publication in October. And of course, I'm very happy for members of the board to contact me for further information in the meantime, if they want to. I think that was all. That was kind of very brief overview.
That's brilliant. Thanks, Jane. It's really helpful to understand where it's at the moment and the lessons that we take forward and the recommendations that might come in terms of comms. I don't know if there's a need at this stage to encourage people to do things more online or not, but that's no doubt what your consultation will be finding the evidence for. Evidence-based decisions, really good. So thank you. Are there any questions for Jane at this stage? No, I'm not seeing any hands up, so thank you very much, Jane. You're very welcome to stay or not, but thank you very much for joining us. Brilliant. Right, the next item on the agenda is the Ics Update and Discussion, which will be led by Sam again, and John Selgren's on hand also, of course, for this item. Thanks, Sam.
Thank you very much, Chair. So I'm delighted to be presenting this session, which is going to focus mainly on the plans for developing the new Integrated Care Partnership Strategy. I'm going to show a short presentation which walks the members through the main points. I guess what I wanted to emphasise up front before we get to the presentation is that we are taking quite a different approach in how we develop the strategy to support the integrated care system. In the past, there's been perhaps a bit more of a professional approach taken where we might develop strategies and then consult on them. That is not the intention this time around. So very clearly, we're taking a deliberate decision to take a lot longer to build this strategy. There will be obviously the usual elements to the strategy where we're using the findings of the Joint Strategic Needs Assessment, population health management insights, some of that technical information about health outcomes where we want to go further and faster in making improvements for our population. That'll all be in the strategy. But right from the start, we're taking the time to run a series of engagement exercises to make sure that this is being built out of a conversation with people, communities, and also our employees from the organisations that are going to be making up our integrated care system. So it's a chance for the board to think about the approach and the principles that I'm going to present to you today. And then I'll finish with a number of questions which it would be good to have a bit of discussion on. And finally, just to sort of seek the board's agreement that you're broadly in approval of the direction of travel and the principles that we're taking. And then we'll break for a bit of a discussion on some of the other developments that have been happening, not least the work of the place-based partnerships steering group. And I'll hand over to John Selgren at that point to update the board. But if you bear with me, I'm going to share my screen again. So hopefully you can all see that. Okay, so as I've said, we're taking a different approach, and what we're really looking for this afternoon is a bit of a discussion in the board, just to check that you endorse the approach that we're taking. Just a reminder of some of those questions that I'll be revisiting at the end. I'm looking for agreement with the 6-month timescale and the general approach. Do you agree with the design principles that we're presenting to you today? And a little bit of thought about how the integrated care partnership strategy connects with the joint health and wellbeing strategies of both health and wellbeing boards. And then if there are any burning questions that you feel that we need to be asking when we have this continuous conversation with communities, please do let us know. We're starting to collect ideas for what we should be talking to our communities about, as well as letting that conversation develop naturally. So this just shows you the formal strategy and planning requirements as set out in the guidance and the legislation. So right at the top are the health and wellbeing boards who will be responsible for approving the integrated care partnership strategy, which is set out in the orange box here. There needs to be a link across, as I've said, to the joint health and wellbeing strategies, which we already have in place. But the ICP strategy is really important because it almost sets the ambition, the tone and the culture of the sort of work that we really want to see prioritised in our integrated care system. So if we're really going to make a difference to people in communities, if we're really going to put a broader approach to health and wellbeing at the heart of the efforts of all of our organisations, then what we say in the ICP strategy is really important to then in turn set the direction for the integrated care board strategic plan, the operational plan, which will also pick up on national requirements for integrated care boards and integrated care systems, but also organisations' operational plans. So it's a really, really good chance to really have a deep conversation with our organisations, our workforce and our communities about the sorts of things that we think are going to be really important if we're going to continue to drive improved health and wellbeing, better use of resources and improve services for our residents. So as I said, the ICP strategy will set the direction for the ICB strategic plan, and the board, that's the integrated care board, will be responsible for making sure that their 5-year strategic plan takes its main direction from that ICP strategy. In terms of what the LGA and NHS England guidance is saying, the ICP strategy requirements need to broadly cover health and social care needs of the population. It can look at wider determinants of health issues such as employment opportunities, the role of environment and healthy places in improving health, housing issues, but above all, it needs to highlight where better coordination and better effort between all of our partners could really improve the way that health and care is provided for our residents. And some of the themes there should be familiar because we've visited them previously in the STP plan and to some extent the NHS long-term plan, helping people to live more independently. How do we support people to remain independent and healthy, perhaps without as much recourse to public services? Can we start to take a holistic view of people's health and make sure that interactions with services consider the whole person and not just the presenting condition? And above all, how do we start to really narrow the gap in some of the inequalities in health outcomes that we have seen for a long time in the Dorset system and improve the experience of the way that people are using services? If we're getting the ICP strategy right, then we should be creating a framework that allows all of our partners, including councils, to understand where we can focus our efforts more on interventions that will reduce those inequalities over time. And really important that we pick up a strategic plan to improve early life chances. If we're getting the best start in life right for most of our population, that's where we'll see the best possible chance of medium to long-term improvements in population health. So the Integrated Care Board and local authorities will be required by law to have regard to this strategy. So it's really important that we take the time now and we engage as widely as possible, both with our system boards, our organisations boards, but also our people and communities to make sure that we've got the right issues covered by the strategy and that we're deepening that dialogue about where we can make a difference together. We're not starting from a low base, and actually if you look at the sorts of strategic plans that we've already developed in previous iterations of the shadow integrated care system and also the two councils' corporate plans, there's a lot of similarity when you look through the language and the stated ambitions and the priorities of what the public sector wants to achieve in the Dorset system. So we're building on the STP, the Sustainability and Transformation Plan, the long-term plan, which picks up some of the NHS work on prevention. We've got a decent history of joint strategic needs assessment, and we've started to change that process away from just a technical consideration of health outcomes to something that's a bit more like an engagement process. And we've been hearing from all sorts of different people in relation to some of the key issues affecting our residents. And we've got a good history of collaboration, both within health and wellbeing boards, but also between health and wellbeing boards. So I'll just remind board members that it was the joint work between the Dorset and BCP, although it was the Bournemouth and Poole Health and Wellbeing Board at the time, that led to the development of the Prevention at Scale plan in the previous STP. So we're not starting from a low base. There's a lot of similarity. The key point really is how we sort of boil all of this down and close the difference between perhaps what people and communities are saying that they want from health and care services with the professional view. So that's the work that'll be done over the next few months, and I'm hoping that this will all build into a really effective, but above all, a well understood and well owned strategy that people recognise can really drive value. So just in terms of the design principles, we're aiming to deliver a common message, whether we're talking to employees or the public. At the end of the day, a lot of the people who work in the health and care system become members of the public when they finish their shift. So I don't think that it's helpful to see those two groups necessarily as different. We are signalling that this strategy is the opportunity to do things quite differently, moving away from an expectation that there would be certain things in the strategy perhaps expected by government, for example. This is our opportunity to talk about some of the issues that are most important to our residents, not necessarily what might be expected. It's a way of building shared commitment from all of our partners. So by taking time, by taking a co-design approach, by talking to boards and talking to residents, communities and our employees, we're hoping that that will build engagement, it will build commitment to doing things differently and surface some of those things that people are really passionate about, that if we were going to look back in 5 years' time, we could say that actually that was the point where we started to really come together and push to the front some of the most important issues where we want to see real change. And if it's co-designed and we're doing this with people and communities, then we've got a much better chance of some of these changes being understood and sticking. We do need to take time. This continuous conversation approach is going to be something that we want to commit to very, very strongly. It's not a 6-month period where we will be having some engagement conversations and then coming out with the strategy as a process that finishes. I think it's quite likely that where we get to in the autumn will be, if you like, stage 1 of the strategy, but there'll be a number of issues that have been surfaced through the engagement process that we'll have to continually revisit through further engagement cycles if we need to develop more understanding, a greater degree of ownership, and really unpick and understand how to make a real difference. So this is very much a draft timetable for the development process. And broadly, we'd be looking to continue an engagement process right the way through to the summer, when we'll then start to surface that insight. We'll start to draw together some of the main themes, the priority outcomes that people have mentioned that they think is important for the strategy to focus on, and then synthesize that into a draft document and start to go through the approval and the review phase. Just to show you a kind of graphic that simplifies what I think we'll be into on an annual basis, we'll be using some of the technical public health and population health information alongside key views from the health and wellbeing boards in each place in terms of what we should be focusing on, as well as the public engagement findings and community voice from a series of depth interviews, service user interviews. All of that will be blended together into an understanding of what we need to focus on in each place, and that then will inform the framework and the structure of the strategy, and in turn it will inform the actions for the Integrated Care Board and our local organisations. And I think the best way of doing that is through an annual review process. We might have something where we come together as a workshop as the Integrated Care Partnership to review the data, so there'll be a bit of a technical exercise, but we'll also be listening to people's concerns and also gauging the strength of feeling about some of the issues and the conversations that we've had as part of that strategy development process. So what we see at the end of the first phase may well be, as I've said, stage 1, and we just need to be clear that this is not going to be a one-off opportunity and then we finish the process. This is a continuous process of checking back to make sure that the direction we're heading in is the right one, that we've heard the right issues and that we're picking up and able to report back on progress that's being made with them. So just on to the questions. This is the final slide, really. The first one is just to think about whether you agree and support this timescale and approach for the first phase of strategy development. Do you support the design principles and what I've talked about today in terms of the approach that we're taking? Are there any thoughts about how the ICP strategy should reflect the current work that's gone on in the Joint Health and Wellbeing Board strategies, and how should we join those up? And then what are the questions that we really need to be talking to communities about? Some of that will emerge through the engagement that we're planning, but if organisations represented on the board have got particular interest or issue in questions that we need to be asking of our communities, it would be really helpful to hear those today. And then my fifth question here is, we're really looking for support for a development session to work through the findings of the Joint Strategic Needs Assessment for the Dorset Council Place, and to couple that with some of the engagement insights that we already have to develop a Dorset Health and Wellbeing Board view of local priorities and important themes that should go forward as part of that strategy development process. And as a sort of little framework, that's likely to be population health outcomes, where we feel perhaps a bit more progress needs to be made, and particularly areas where we want to see the gap closed in outcomes between different communities. We might be thinking about health and care pathways where we could do better together. And then above all, what are the opportunities to work differently as a system? If we're going to work differently and really make a difference, what are those thoughts about areas of transformation or change where we could perhaps go further and faster? Then my final slide is just some additional timelines that were mentioned by the white paper on integration, which came out a month or so ago. There'll be further guidance for integrated care partnerships expected July 22. We're required to have an ICP strategy for December 22, but we're aiming for around about an autumn sign-off. There'll be further guidance on how health and wellbeing boards will work with place-based partnerships and integrated care partnerships. And then the 5-year plan for the integrated care board is required by April 23. That will be followed by a shared outcomes framework, which needs to be agreed locally in April 23, and then place-based plans for the place-based partnerships agreed and in place also by April 23. And then you can see the direction of travel. They're predicting a move to delegated budgets and pooled resources at place level by 2026. And there's also a national requirement for all ICSs to have a population health platform to support joined up care by 2025. And we are well on the way to having that with the DICE system that we've already got in place. So a lot of strong work already in place locally in the system around population health. And then the national priorities and operating plan will continue to come out each year, but there's a sense of much more freedom and flexibility for local places to agree additional priorities and to perhaps change the emphasis in where we want to see our local efforts in our local system. So I'm going to pause there. I'll just take my slides down for now, and then perhaps invite John to join the discussion for an update on the place-based partnerships work.
Joe, that'd be helpful. Do you want to take some questions first, or do you want me to just?
Well, I'm just wondering. I know Peter Wolf has got a time issue, and he hadn't raised his hand, and I'm just wondering. At some stage, Sam, you might want to put the questions back up, but after John's done his bit. Peter, do you want to step in just before John?
Yeah, can I the questions I'm going to ask Sam will be aware of because I've discussed them with Sam, and Patricia may remember I raised these with her. In terms of defining the strategy, I'm really keen that we review the governance, the terms of reference, the functions and the ICS role and of ICS and the various organisations, and amongst that I count the two health and wellbeing boards, the various local authority health committees, scrutiny and overview, the Public Health Dorset and ICS. And my question, which is a concern that you are aware of, Sam, is that there is not enough clarity between the roles of each of those organisations and functions and committees, and there is potential for, in tennis doubles sense, either a clash of rackets or the two players watching as the ball goes whizzing down the middle. And I think that's one of the first things you should be doing, or we should all be doing, to make sure that we've identified everybody's roles, and that's what they are doing and what they shouldn't do. And I haven't seen enough of that in what you've just said. And the second thing, I was looking at the vision statement for a hospital looking for a chair, and the vision statement was all about care and the quality of care, but it was nothing about customers. It was nothing about how people felt, and it was all about improving the quality of care such that surgeons and practitioners could feel that they'd done a brilliant job, and that's fine. But we don't seem to think enough about customers. So that needs to be fed into the system. Are you going to give me some satisfaction that yourself and Patricia and us are going to work at that to make sure it's going to happen? And thank you, Patricia. I knew if I said that, that would encourage you to come in. Sam.
I'll give a very quick response and then allow Patricia to comment. I think that absolutely this is what this process is about. And as part of the engagement, I've said that we'll be engaging with the public and communities, but we're also going around and having this conversation with all of the boards, including the organisation boards in the system. So there are two things that need to happen. There's further guidance expected about how some of the boards will operate and the relationships between them, particularly Health and Wellbeing Board, place-based partnerships, the Integrated Care Partnership Forum. But also we need to listen to the current concerns and make sure that we're much, much clearer when the landscape is finished. Can we be clearer about, you know, what work is undertaken by which board and the governance and the relationships between them? So the point's well made, Peter.
Thank you.
Thanks, Sam. Patricia, do you want to come in on this point?
Yeah, thanks, Rebecca. Yeah, Peter's got some very good points, and I think we just need to accept this is an iterative process at the moment because it's about setting up a new organisation, and we are subject to continually changing guidance from NHS England as they get their heads around what this is supposed to look like. So we have done a lot of work internally within the ICB around its purpose, its terms of reference, the subcommittee structures that will support decision making. We've done very little on the Integrated Care Partnership at the moment, and that's primarily because the guidance is in its infancy, and whilst Dorset may not be touched very heavily with local elections, other areas are, and so until we've passed the point of purdah in the elections, we're not expecting any further guidance from the Centre on ICPs until later in May, and then we'll have to move at pace to get that set up by July. With respect to organisational visions and strategies, I think it's fair to say that we've still got a way to go in terms of everyone being on the same page around their role in system versus organisation. And one of the things that Jenny and I have talked to organisations about is that when the integrated care strategy is developed to a level that we're able to discuss the contents of it, respecting what Sam said about we'll probably be going through several iterations over 2 or 3 years until we land on a document that we're fully comfortable with. We've talked about asking organisations to come to the Integrated Care Partnership and present a brief overview of their own strategies so that we can all hold each other collectively responsible for making sure that we're all sharing a single purpose and we're signed up to moving in one direction. The other thing I need to say is I am so excited about the fact that Sam's agreed to do this piece of work.
I think we all are.
Thank you.
Sorry. Right. Forbes. And then I will get to John. Sorry, I've got a book.
Yeah, so I could comment a lot on the Sam's presentation, but we'll get to that. I just wanted to pick up specifically on the quality of care comment. So a very significant pillar as part of our assessment of quality of care as a clinician. It's not about me feeling better, although I do feel better if patients have an appropriate experience, but it's very much about patient or user experience. And that is part, I say, a major pillar in determining the outcomes. So you could call it customer experience, but it is part of the overarching principle of delivering quality or qualitative care.
Thanks for clarifying. That's really helpful, Forbes. Thank you. John.
Thank you. I'm sensing we probably want to get into discussion, so I'll be extremely brief on the emerging thinking on place-based partnerships, but perhaps we'll pick up more in the course of that discussion. Really, firstly, for me, just to point out 4 key things from what Sam's said, which I think are very pertinent to the work we're doing in the place-based partnerships work stream. The first is to recognise that we really start from a good base in terms of our clarity of strategic direction across the council and the various organisations that are involved, and that really does help, and the strong analytical base that we've already got. The second one, and this is very much reflects on something I'll come on to talk about in a moment, around the design principles that Sam listed in that earlier slide, and in particular that point about co-creation. This is an opportunity for all of us, not only those who provide, but particularly to work with communities, I stress with rather than to, in terms of making sure that we do improve outcomes in exactly the way that Sam described. My third point is that this, of course, is a process of evolution. Again, Sam's slides are very helpful, indicating that this is something that's going to emerge over a period of time. And in fact, when I talked to the group recently, I said some of the work streams, of course, are working towards that deadline of around the summer of this year, very much the place-based partnerships. Although we are starting work now, in reality, our work will almost start at that point. So we'll really begin to get going from that point on. And then the fourth point from Sam's presentation I just want to underline was the point about that annual review process. This isn't something that is static, but something that involves. And that will just take me on then to explain what we've been seeking to do in the place-based partnerships work. First bit is just to clarify the form and function, to do that kind of technical bit of the work again that Sam made reference to and Tricia referred to as well. But the key bit has been to think about that delivery process. And for us, that's been around recognition that what's going to be so critical is effective leadership of the system as a whole. And going back to Sam's point about co-creation, that for me is really, really important. So one of the things that we've done to support that is to plug into the national place-based programme. I'm pleased to tell members of this board that there are a very large number of people from the Dorset Partnership that are currently on that. And we think that will do a lot to help give us that capacity, that cast of mind, that approach to how we're going to work on this co-creative basis moving forward. And the other thing that we've done as part of that is also talk about reaching out to some other places where some of the things that we're aspiring to do have perhaps been done already, or they've got some early thinking on that. So we've begun to reach out to some other parts of the country where we think some of those that practice can be drawn on, just help us on our journey. I think, Chair, in fairness, that's probably a quick, I did offer you a quick summary, so I'll try and be quick. So I'll perhaps pause that point because I'm sure we can pick up some of the wider points in the general discussion.
Thanks, John. And right, Sam, how would you like to go ahead and you're going to put those questions up?
I'll put the questions back. If you bear with me, I'll just grab the slide again.
There was quite a lot in your slide deck, which members have asked if they might have copies of. And it might be that some need to digest a bit and feed back to you after the meeting as well. Is that all right? I know you said you want some feedback today, but would it be okay also for others to dwell a little and come back to you?
Yes, absolutely. And I think that's why question 5, when we have a development session in the next month or two to look at the JSNA outputs, it's also an opportunity to revisit some of those first 4 questions. So there'll be lots of opportunity, I think, for the board to continue to have this conversation about what we feel is important for the Dorset Council area and to reflect that through as the view from the Health and Wellbeing Board. So absolutely, any quick thoughts today would be helpful, but equally more than happy that the slides will be sent out via George. Thank you, George. And if people have got thoughts after the meeting today, I'll perhaps post my email address in the chat bar. More than happy for people to contact me.
Brilliant. So, everybody, anyone got, and it doesn't have to be in the order that they're in. We're not going to do 1, 2, 3, 4, but any feedback from anybody? Forbes, then Simon.
Yeah, thank you. So, I mean, overarching responses very positive. Patricia said she was really excited. I think it's really helpful today to actually see this laid out, Sam, and I would say very clearly. So for me personally, and I'm sure I speak for many colleagues, that I absolutely agree with the timescale and the approach. Some more work needs to be done, certainly around connecting the ICP strategy and the 2 health and wellbeing strategies. And personally, I feel that does need some time spent to get to an agreed aligned outcome. It doesn't mean it will be the same for each place, but there will be appropriate alignment, and where there's divergence, we understand where that exists. I absolutely favour taking it out to our communities, and we need to make sure we take it to all of our communities rather than just, perhaps a smaller section. And it will be about what would make a difference to them in their lives and in their place, wouldn't it, generally speaking? That would be the principles of what I would be asking, because we very much know we do not have a one-size-fits-all in terms of population and the inequalities that exist in Dorset. I'm sure you're planning to do this, but I would like to take this work to some of the groups that I'm involved in, particularly thinking of our GPs and our clinical networks, because they would be interested. They're very interested in this work, and they'd be interested in engaging in the strategy and the place-based work which John's described. Thank you.
Right, Sam.
Yeah, thank you, Forbes. Yeah, thank you for the suggestions as well of some of the other groups that we could engage with. I'm supported by a brilliant team. It's not just me. Kirsty Hillier will be leading a lot of the planning around engagement with people in communities, but we've also got some really, really good people coming forward from right across the system who'll be helping with the engagement process as we start to take this through the right groups, because there's a lot of them.
And some of the work that is ongoing with our stock take of the Health and Wellbeing Board strategy, Forbes, it's actually a really good time that we've done this, because actually we might be seeing there's a part 1 and a part 2, one which fits really well with the ICP, and then there are other things outside of maybe the ICP strategy which fall into the Dorset Health and Wellbeing Board rather than the BCP Health and Wellbeing Board. But we'll get to that item in a minute, and hopefully it'll help draw that out. Simon, I've got Simon Raw.
Oh, yes, thank you, Chair. A couple of questions, really. I mean, firstly, the key word in this is integration. And I wonder if our design principles ought to reflect the need for integration more strongly and where that would feature. So within our existing system, there are already big disconnects and inefficiencies and costs associated with lack of integration and process inefficiency. And by putting more things together, I can see that only increasing. And I wonder if our strategy ought to be setting out more clearly how we're going to achieve better integration, not at the headline level, but at the operational level as well, because those kind of things can drive significant dissatisfaction for customers. It can drive costs, increase costs, and it can drive poorer outcomes. And it's very easy to think of examples to support exactly what I'm saying there. So I wonder if there's a design principle that we need to look at and include there. And then when we look at the questions we need to ask communities, I'm agreeing with absolutely building on what Forbes has just said. Clearly our communities break down into a very wide range, but there is the public, the general public, all the clients of our health service. And we also have special interest groups, people who perhaps represent ME sufferers or whatever. There's lots of special, and I think how we approach those could be very, very different. But in terms of one of the public perceptions, I've just seen the survey that says that satisfaction with our NHS has plummeted and is down at very low levels. How does that feature in addressing what our communities want? And would that be considered to be one of the measures of success in actually delivering to our communities?
Thanks, Simon. There's lots of good points in there. I guess I'd hesitate to give an answer at this stage, but what I will do is I've taken a note down. I definitely think that this is an opportunity to have what I took by your comment was it's easy to talk about integration at a high level, but when you're actually getting into the pragmatics and understanding from a person's perspective of accessing services, what is it that really frustrates people? How are we getting it so wrong at small areas, and what could we do to, I think this is going to be about unlocking the ability of people on the ground to perhaps think differently about how we join up health and care. So although this may look like it is a big top-down integrated care partnership strategy, I see it more about setting the framework and the ambition and liberating us to think quite differently about genuinely working with people, taking on board those views, being honest about where we think we can make changes together, but also being honest about where there may be some expectations that need to be managed. We clearly can't do everything. So in the background, there's also an ongoing conversation about effective use of resources. And I think we need to be much more honest as part of this strategy process around how professionals and statutory organisations use our public money. But also the other side of that coin is, how do the public also use resources, given that they are scarce? We can only use them once. So what's the best way of a partnership that finds a way through that, given that there probably is waste and inefficiency, but we may be a bit defensive when we're having that conversation with the public. So let's be open, let's be adult enough to have that conversation and genuinely listen where there may be some fantastic ideas about things that just don't make sense from the perspective of the user. I think you've hit on a really important point about the different ways that we are going to need to have conversations with the public and special interest groups. I'm not going to respond to that now, but I'd just like to assure you that I will be working with Kirsty to think through how we do that properly, because the sort of conversation that we might be having with someone who's living with a particular condition, which has a big impact on their life, will be very different to the type of conversation that we have with an ordinary member of the public who may not understand what on earth is an integrated care partnership, let alone an integrated care board or a strategy. So I've made some notes. I think that they are really helpful pointers, and if you would like to remain engaged in the process, it'd be great to continue to have your insight and input as we go through it.
Yeah, thanks, Sam. I'm very happy to. Yeah.
You mentioned some examples that came to you very quickly, Simon. Perhaps you might email those to Sam just as indicators of what direction you're coming from.
Yeah, absolutely. I think we could all think of examples, but yeah, I'm happy to mail some specifics.
That would probably be really helpful. Patricia.
Thanks, Becca. I think those are really important points that Simon raises, and you won't be surprised to know that this is the most thing that Sam and I have talked about in the last few weeks, is that supporting our colleagues to actually engage in not just a co-design or co-production exercise with our communities, but also wanting them to be actively involved in the how services are delivered, which gets to the heart of Simon's point. And I was on a national meeting this morning with Mark Cubban, who's the delivery director for the NHS, talking about the long-term plan and the refresh of that, and having that very debate around wanting the public to be at the front and centre of this development, and not for it to be seen as a top-down governmental or NHS England piece of work, and that needs to start, that approach needs to start from the very top of the NHS, where we've got a long-term plan with a set of priorities, which I think if I showed some of those priorities to the public, they would not recognise those as being the things that are important to them. So we've got to get to that place where we really are co-designing and co-delivering services with them. And that needs a different approach, and it needs more listening, and it needs a more of an open approach to wanting to do things differently, and it requires a less paternalistic approach that's been taken in the past. So I don't think we should underestimate the challenge that will bring to our teams around trying to get them into that space. But I also think that another conversation we had this morning is wanting to be honest with the public about what the funding can realistically deliver if we work differently, and accepting that the public are actually a lot more intelligent and sensible and reasonable than the national teams give us credit for as citizens. And actually what we've seen in the north of England especially is honest conversations that put communities front and centre of the decision making. Also then means you can have trade-off conversations with them about what money can buy and what it can't. you can more easily manage expectations, and people start to use public services in a much more responsible way because they're part of the decision-making process. And I think that's where we as an integrated care system would like to get to, recognising that that takes time, but that's the space we would like to find ourselves in, so that the public see themselves as a partner, and also that they absolutely then see that public service adds real value to their lives in the areas that are important to them.
I can think of the reflection back on things like the Wigan deal. Yeah, which I think is really interesting.
And
so
having lived down the road from Wigan, I can tell you it's not the most scenic part of the world. So for Wigan people to now say they are the happiest conurbation in Greater Manchester says a lot about the control that they feel they have over their own lives now.
That's really it's really good. That. Thank you, Patricia. Right, Sam, I can't see any more hands up. A couple of comments in the chat bar, but which you can see. So slides will go out, and from the questions, I would say that number 5, let's have a session is a done deal. We should be doing that. And I think it was number 3 which Forbes pulled out, which was about the ICP and Health and Wellbeing Board strategy. Yes, that's a really important one. It sort of fits in with some of the points that Peter Wolf was mentioning about getting the governance right. I think a lot of that could form a good workshop. That's when you're ready, Sam. That'd be really good. John's got a hand up. Hi, John.
Just to add to that, and to keep picking up the flavour of what Tricia was saying a moment ago, that those critical success factors I was referencing in the comments I made about the place-based partnership work, to reach out and understand what those places that have got this right and are clearly making good headway with some of these things, I think that'd be hugely helpful to us. So almost what we could begin to do is talk about what it would look like. How will we know when we've got there? What will success be like for us? And I think if we could begin to describe that in outcome terms, not just about the process, but how will it feel? How will, I'd really warm to that bit that Tricia was talking about, how we'll make our citizens, our residents much more engaged with the service they provide. And I think that's right. It's almost that sort of citizen contract thing of the public recognising that, you know, we're all stewards of our own taxpayers' money in that sense. And if we can get to that sweet spot that places like Wigan have moved towards, I think that would be really helpful if we could think about what that might be and what we need to do to get ourselves to that position.
Yeah, really. I think you're right, John. And that's probably something that maybe Kirsty, along with those community leaders, we've got many in all parts of Dorset, will know the groups who can actually provide that sort of way of working locally and sense what a place feels like and what are the issues that are affecting them, and what, for instance, in very rural areas, it's access. But that'll be different in other parts. So I feel there are sort of 2 sessions that we need to take forward. Peter.
Sorry, can I did tell you I was bizarrely going to see my doctor shortly because I'm suffering from long COVID, so I apologise, I'm going to have to go. The paper that's come up on Better Care Fund has got my name. I have seen it and been through it in some detail, and I'm extremely confident in the brilliant work of Sarah from our side and Kate from what you might say is the other side. And if there are any questions, I suggest you put them through to Sarah or Kate. The second thing is, I was going to raise in another area, but I'll raise it now. I've been through with the team here the various adaptations and IT work we're doing in order to support the prevent agenda, because we've got a number of pieces of kit and of technology that are being used precisely for that reason. We've got a small sort of area, what you might call a little incubator that we use in County Hall, that we're moving to another room in Maiden Newton. But personally, I think it would be great if we could get members of this board, and I'm sorry I've not raised this with you before, Rebecca, this board out to this room so that they can see the good work we're doing, and that could even act as a bit of a focus and a starting point for some of the workshops you talked about, because it can demonstrate the opportunities that are open to us, and it's not just what Dorset Council are doing, it's what we're not doing, so we're happy to listen. So sort of two things. One is the presentations that's coming up. I'm very confident you will find a lot of information, but I would add that it's incredibly content rich. And Rebecca said something earlier about people perhaps coming back later and considering it. You may want to do that on the Better Care Fund, because there's just so much there. And if you wanted to fix an away day or an away half day around looking at the work we're doing in terms of IT, I would be really pleased to host that. And it's something we'd be delighted to do. I'm gagging to show it off to you. And I think it would just start a series of conversations, but that's obviously entirely up to you, Chair.
Thanks very much, Peter. I did see it. Well, it was 2 years ago now, but even then it was really impressive. So thank you. Maybe we'll get a bit more of a brief of what it's all about and get that arranged. But thanks very much for your contribution.
I'll send you a private briefing note on it, and then you can,
that'd be really good.
You can decide how appropriate it is, either at the Sam Crow away day or any other away day.
Okay, brilliant. Thanks, Peter. And I hope the doctor gives you some good medicine.
More steroids.
Oh, right. Okay, Sam. I think that we need to move on. There was some really good mentions there of things to think about, and as I said earlier, this isn't just for today; it's ongoing. So I'm sure.
Yeah, thank you, Chair. It's been really helpful, and we'll get on and design a development session.
Brilliant.
Thank you.
Thanks to you and John. Thank you very much for your time. Right. Next item on the agenda, which is sort of linked to this, and I hope I'm just going to say that Rupert Lloyd, who's going to present this along with Paul, has done a huge amount of work, but also you lot have also done a huge amount of work. So thank you very, very much for feeding back to the email. It's proven to be a really good exercise of inclusion from one meeting to the next. I know it's taken some time, huge amount of time for Rupert and Paul, but your time as well. It is really, really appreciated and has provided some really good ideas and ways forward, and spotted holes and spotted some real positives. So away with Rupert and Paul now. Thank you.
Thank you, Chair. I'm just going to share my screen. And excuse me, I'm suffering with a bit of a scratchy throat, so hopefully my voice won't give up on me entirely. Okay, hopefully that's come through okay and is full screen for you all. And hello, my name's Rupert Lloyd. I'm part of the team at Public Health Dorset. And as Councillor Knox says, I was asked to review the information that board members had shared with us as part of this stock take and try to tease out some of the headline themes or early findings from what you've shared with us. And I also wanted to just echo Councillor Knox's thanks, because you did share a huge amount of information with us. I think we had over 90 slides in total, and there was real breadth and real detail in what we heard back. But I am going to apologise that we've had to do, to echo Sam's phrase earlier, quite a lot of boiling down, and we are going to be sharing headlines with you with some quite wordy slides for the next 15 or so. But hopefully you'll find it a useful process, and it will give you some useful insights into what the board is doing in its entirety. In terms of the approach we're going to take, we're going to look at each of the three priorities from the board strategy and kind of shape the slides around the questions that we posed to board members and which you responded on. I'm going to talk through some of those kind of headline themes or findings, and then Paul will come in with a bit of a focus on some of the kind of emerging themes which the board might want to give more consideration to moving forward. So the first question we asked was, what engagement have you completed and or do you have currently underway with communities that can inform the board's action on improving healthy life expectancy? And something that came across very clearly was the role that the voluntary and community sector provides as a foundation that enables partners' engagement with communities, with numerous smaller groups facilitating engagement, supported by a web, if you like, of some of those infrastructure providers like DREC, Dorset Community Action, Healthwatch, and so on. We heard about some of the engagement that partners have already completed or have underway at the moment with specific communities. So some of the focus on engaging with children, young people and families, with older people, and on understanding some of the barriers faced by inclusion health groups. So homeless people, for example, thinking of some of Dorset Council's and some of Healthwatch's work, and also with geographically defined communities, so Weymouth and Portland, for example. And what we also saw is that across partners' engagement with communities, there's quite a clear focus, as you'd expect, on enabling care to be provided closer to home and supporting independence. So things like fire and rescue services, safe and well visits, care closer to home, which is Dorset County Hospital's acute therapists outreach programme, and Dorset's community response, which is a pilot enabling people to access support direct from their communities that we heard about from adult social care at Dorset Council. And thinking about some of what we heard or touched on in the previous discussion, we're hearing about what partners have, or how rather partners have committed to co-production and co-design of action with communities. So an example of that is DC Adult Social Care's co-production approach to thinking about day opportunities and future approach to day opportunities for adults with care and support needs.
So some suggested themes the board might wish to consider further to strengthen delivery of its health and wellbeing board. Following on from that first set of questions, can we do more to ensure that engagement is shaped by communities themselves? This would help us focus on what matters most to those communities and provide a sound basis for co-production. And secondly, are there opportunities to better understand inequalities in our communities and how we respond to them? So something there about our partners' use of engagement and deployment of effort and resource weighted proportionately to reflect or best reflect needs.
Okay. So the next question that board members responded to was about what partnerships, including and beyond with other board members, do you have in place that contribute to improving health and well-being? And this is, I'll be honest, a bit of a cherry picking of some of the examples that we heard about, but thinking about how board members are working in partnership, or we heard rather that board members are working in partnership across different dimensions and different scales. So we heard about things like building health partnerships across the NHS, local government and VCSE. And then from Children's Services, the strategic and local alliances for children and young people. So a very clear example of where partnerships are happening at the quite local, hyper-local scale with an overarching supporting strategic partnership supporting and working with that. Then we heard about the focus of partnerships efforts on improving health and well-being and how they share a number of common themes. So those include action to reduce health inequalities informed by Dorset Intelligence and Insight Service, so the DICE service, and also a focus on improving the home environment, supporting a safe home environment to support independent living. So again, things like the safe and well visits. And we also heard about how partners are supporting routes to employment for vulnerable groups. So an example there is Dorset Council's work that's ongoing, I think, on expanding pathways to employment across the council for care leavers. And a kind of second question that supplemented that was, what processes do you have in place with partners and communities to measure the impact of your work on improving health and well-being? So we heard with HealthWatch as an example I've included on the slide about how some partners have established theory-led approaches to evaluating the impact of their interventions and programs. And what I mean by that is examples where there's a very clear thread running through programs and interventions from identifying outcomes that you want to achieve, through to understanding how you'll measure whether you're achieving them, and then how you feed back on that measurement and that understanding. We heard about how partners are making use of national surveys like the biannual social care survey. And we also heard about how partners have plans in place for measuring some specific health and wellbeing outcomes as part of their kind of core contract monitoring processes. And again, the role of the DICE service was highlighted in terms of how it's supporting population health management. And one of the examples we heard of there was how DICE has supported or enabled a system-wide overview of COVID-19 vaccination uptake, which supports individual organisations, individual parts of the system to play their part in the rollout of vaccines.
So from those two questions and responses we got from colleagues, two suggested themes the board might wish to consider further. So we noted there that partners have reported mechanisms in place at a variety of different geographies or different levels, giving insights which could perhaps better support how we identify opportunities for going further faster, for enhanced collaboration between different organisations. That might represent additional work, but there's a question there about whether there will be appetite for doing this. And a related sort of topic, would board members value more regular updates on the outcomes that individual organisations are working towards achieving and the progress that they're making towards those aims?
Okay, the next priority from the strategy that we focused on was promoting healthy lives, and in particularly setting priorities to accelerate work, promoting healthy lives and well-being with a focus on physical activity. And the first question we asked, I think, was that one about culture and leadership, and what board members are doing to support that kind of reframing of physical activity away from exercise towards daily movement through some of the language and behaviour exhibited by leaders in your organisations. And we heard very clearly that partners have recognised the impact COVID-19's had on your workforce's well-being, particularly through things like, in some cases, for a part of the workforce, through increased home working and sedentary behaviour. And we heard how you're encouraging movement as a kind of integral or a crucial part of improving well-being. Then we heard about how partners are taking steps to encourage staff to build breaks into their working day and use those specifically to support movement. So things like walking, stretching, building active travel in where they can, some good examples of that. And we also heard about the channels that board members have in place for sharing information from activity providers through internal comms, newsletters, intranets, and so on. And we also had some great examples from across the board about how leaders are making their personal commitment and participation to movement visible in their organisations. So through some of the things you're doing, like blogs, videos, and team walks with senior leadership. So kind of walking the walk, I suppose, to sum up that bullet point. And then finally, we heard that partners are developing some clear, inclusive messaging for staff, which is framing movement as a component of well-being and feeling good in lots of cases, rather than something which is about performance, competition, and sport.
So a couple of themes for consideration here that might help us strengthen delivery of the health and wellbeing strategy. Some of the language and behaviour that's been reported emphasises particular types of activity or movement, such as sport. And leaders could clearly build on this to communicate the value and support they place on building on a wider or all forms of movement into the working practice. So ideas around around walking meetings, being active in travel options. So that's the kind of leadership agenda. And then looking at all staff across partner organisations, can they further emphasise the value to individuals and organisations of daily movement? So looking to perhaps include this as part of team management discussions, as indeed we note in the feedback in the stock take some partners are already doing, but can we widen that across the partnership?
Okay, and the next question I think kind of moved on from the question about leadership and culture to look at some more specifics about how organisations or how board members are creating opportunities for people to build movement into their daily lives as part of what their organisation does. So we heard a pretty common theme about how board members are providing information on opportunities to be active across the system through promotion of Live Well Dorset and its activity finder. And we also heard about some really tangible on-site facilities that partners, board members have that support movement at work, like fitness facilities on site and other bits of infrastructure. And then we also heard about how partners are supporting communities to become more active through or in an integrated way with some of the services and interventions they provide. So an example of that is the road safety training that the Fire and Rescue Service provide for young people and how that can support and enable people to engage in active travel.
Four themes for consideration here. Are partners measuring if and how their workforce is moving more as part of this everyday working day and the movement towards moving more in the working day? And is there any tracking that's being done of the impact of this on wellbeing? So that's the first sort of possible area for consideration. The second one we teased out was whether the increases in being physically active is consistent across all different parts of the workforce. Are there equal opportunities or encouragement to all different types of staff in our workforce? There's something also around whether partners have plans, aspirations in place to modify structural changes to buildings and estates that would actually support movement by staff, visitors, patients, communities. There's some evidence of that coming through, but can we accelerate the pace and visibility of these plans? And then the fourth consideration here is, can we go further to shift workplace culture towards promoting movement by actually looking at how the workplace design impacts on or could support encouragement of physical activity? So something there about can we create active workplace environments, which could be as simple as the notion of standing desks.
Okay, and then the final question was a bit of an outward-looking one, which is what is what your organisation is doing to connect people to the existing opportunities outside your organisation for supporting and encouraging daily movement. And some familiar points here, I think, from the previous slide, but perhaps with a more outward-looking slant about how partners are promoting and signposting people to organisations that can support them to move more, like Live Well Dorset that we have already heard about, but also Age UK, some partnership programs like Stepping into Nature. And we also heard, building on that, about how partners are collaborating to integrate support to move more into care pathways focused on those who can benefit most. So a great example of that is Live Well Dorset and Active Dorset's presence in the Dorset Health Village at Southwarks House. And finally, we heard about how partners are building capability to connect young people and children and young people rather, to opportunities to move more. So there's a development in a pipeline to replicate that activity finder approach from Live Well Dorset to provide a similar resource for children and young people. And then finally, the third priority was about support and challenge, how the board provides governance and support to our partners, prioritising the delivery of key partnership outcomes. And the question that you said back on here was, what actions are you taking to improve outcomes for children, young people and young adults who have special educational needs and disabilities? There was, again, a wealth of information here, and I've picked out a few examples I probably won't delve into in too much detail. I think what I'd highlight is probably the breadth of the activity that's going on and the response that we had to this particular question, and the question we would ask kind of in response to what you've told us is for the board to consider how well are we doing as a board at providing oversight and support to each other in improving outcomes for children, young people and young adults who have special educational needs and disabilities. Is there more appetite to share some of this information and some of the outcomes that we're working towards more frequently as a board and in more depth? And then our kind of finishing point, jumping off point, if you like, after that rapid condensed run through of the information you shared with us, we wanted to leave you with three questions. The first is, what stands out most for you from what you've heard today? And then secondly, leading on from that, are there topics or themes which you think the board should focus on more? And given what you've told us in terms of the breadth and the quantity of the information that you've shared, would you support a board development session to consider the stocktake or perhaps particular elements or themes within it in more detail?
Thank you very much, Rupert and Paul. That like with two of the others that we've just received today, a huge amount of information has just been given. Again, I reckon board members would really like to receive those slides, and I think, Rupert, you would also be attaching the individual responses if permission has been given to do so. There's a lot of cross learning there for some, I should think. Some will think, right, that there's some good ideas going on in that, which can be adopted by different organisations. And then, of course, there are the three questions at the end, but also the questions within the actual presentation itself. So we could, I'll look for some hands up for now, but I imagine the best thing would be to take this and potentially put those questions together on the face of an email, along with the slides for board members to feed back again with any views on those. It's quite a lot to have taken in here, but anyone got anything? Sam, hi.
Hi, thanks very much. Thank you, Rupert. Thank you, Paul. That's really good. I think the very quick thing that stood out for me is just how much organisations are doing and how difficult it's been to keep up with that, particularly because of COVID. And when I think back to before COVID, we obviously had some direction being set by the Health and Wellbeing Board through the prevention at scale work. And we did have regular reporting and were able to start to track and monitor progress. So I'm very interested in that challenge around working more closely with organisations to focus on outcomes and delivery and being able to give the board a sense of progress, particularly in the most important themes. So I think some thinking to be done as we change again as a system to make sure that we don't lose sight of some of the excellent work that's being done. And ultimately, that's a good conversation with the public, isn't it? It closes the loop. We can start to say, this is where we were a couple of years ago, look at the progress and be open to a bit of challenge around that as well, if people don't think that we're working hard enough. So really, really impressive and really helpful. Happy to give further thoughts on email.
Hi, Claire. And then Paul. Claire, then Paul.
Thank you. Thanks. Hi everybody, I'm Claire Shields. I'm the Corporate Director for Commissioning and Children's Services and here for Teresa today. I think I would really welcome a board development session to be able to further develop the themes within it and in more detail. In particular, there has been a SEND review green paper published yesterday, which has some quite significant asks of the system and how we work together as partners around outcomes for children and young people with special educational needs and disabilities and some new responsibilities within that. So I think it would be helpful for us to have a sense check and a check-in on that. But also, like Sam, I would echo just a conversation about outcomes and impact and the difference that all those things together are making. And if we've got any evidence on the particular things that are making the most difference that we might all want to adopt.
Thanks, Claire. I think if we'd asked this question, say 5 or 6 years ago, those slides wouldn't nearly be as busy as they are now. So I think people are getting the message about health and well-being, but that outcome focus and what the difference actually is would be really helpful. But yes, there's a lot happening. Lesley. Oh, sorry, Paul, then Lesley. Paul.
Thanks, Chair. I was just going to really, echo Claire's comments to a degree that it feels to me like the considerations we flagged up in the slides, there's an awful lot there to be addressed, and it would lend itself, I think, to a development session rather than email correspondence. There's something about the richness of the dialogue we generate and how we can spark ideas off each other. So rather than invite comment on the detail of the considerations now, I guess I'm particularly being mindful to direct colleagues to those 3 questions in the chat. But in particular, is there support for a development session?
Okay, thanks, Paul, bringing us back. Thank you very much to the focus. Lesley.
Thank you. So my name's Lesley Hutchinson. I'm the Corporate Director for Adult Commissioning in Dorset Council. And to answer your questions, yes, we would absolutely support a development session, Paul. I think it's really important to have that. And it was actually a pleasure filling the stock take in, to be honest, because we did get the team together to do it and everybody contributed. So it's great that some of the information we provided has made it into the slide deck that you've just presented yourself and Rupert. So thank you for that. I want to echo, however, what Claire has just said. So there is a significant number of adult social care reforms coming through, and that as well needs to feed into this, as Claire has just said about the SEND reforms, the changes that are taking place for adult social care. It does particularly talk about health and well-being, and there is significant reference to the ICS and the ways of working moving forward. So I think we need to take account of that when we do the development session, if that's okay.
Yeah, good, very good points. Thank you very much indeed. And no more hands up. Yeah, as Paul said, put as much as you can in the chat to the 3 questions. Rupert and Paul, is there anything more you'd like to add at this stage?
Could I just say it's been a really interesting exercise. Big thanks to colleagues who provided very full answers, as Rupert mentioned earlier. That's much appreciated. It made it very interesting, and I think, as Lesley just noted, it's an opportunity and a time to celebrate progress that's been made. And maybe that's some consideration we can give to how we might use some of the material that's been collected with that in mind. But also a very big thanks from me to Rupert, who did the heavy lifting on this. So thank you, Rupert.
Anything you'd like to add, Rupert?
No, thank you, Chair. I just echo what Paul said, and I'm pleased that some people found it an enjoyable experience to pull that information together.
The exercise itself must have been really sort of put a focus for people. So that in itself, but just to be aware, everybody, that all this information is going to be added into the design of the strategy. Also, of course, expose areas that we need to do more on, probably just indicated by Claire and Lesley. but a wealth of knowledge, which is going to be very helpful for the future. So thank you very much indeed. And please look at the slides and see what tips or things you might want to adopt in your own organisations, which others might have done. Thank you indeed. Right, I'm now going to move on to the next item on the agenda, which is the anchor institutions. Paul's just going to give us a quick update before we move on to the Better Care Fund. Paul?
Thank you, Chair. It's me to hand over to Rupert, actually.
Again.
Rupert's going to give us an update on the work he's been working with me on in the ICS Health Inequalities Programme. We have 5 themes to that ICS Health Inequalities Programme, one of which is looking at what we can do at ICS level to support partner organisations to go further faster on the anchor institutions model. Board members may well recall we had the Health Foundation come to a joint workshop that we held jointly with this board and the BCP board last September to sort of kickstart some work around anchor institutions. And since that, Rupert's been trying to explore with colleagues where they are at the moment and where we might want to get to with that agenda.
Brilliant. Thank you, Paul. I'm just going to share another slide deck. If you hold on for a moment, please. Lovely. Has that come through okay?
Yep.
Brilliant. Thanks, Paul. Yep, so Paul has introduced that for me very neatly. Thank you, Paul. I think probably the objective for this session was really to bring the board's attention to this area of work and give a bit of overview and highlight what we've done so far, and hopefully leave you with some thoughts or insights about the future. So with that in mind, I'll cover what we've done, some of that learning so far, and leave you with a few thoughts about where we go next. So casting my mind back to where we started, as Paul said, many of you will remember having a session online with the Health Foundation in September of last year. And if I cast my mind back, that session was very much about kind of introducing or reintroducing the concept of anchor institutions and starting to understand what partners were already doing to develop their role, their identity, and their work as anchors delivering benefit for local communities. My take on where we were, perhaps across the system at the time, was that awareness and visibility of anchor institutions and their potential, or individual anchors' potential, varied across Dorset. I think for some organisations, they were very much identifying and acting as anchors, and for others, perhaps, although they were doing the work or starting to do the work and start to think about how they could develop their role in delivering social value and community wealth building, they hadn't necessarily put that under the banner or the label of being an anchor institution. And so as a result, we did have that kind of mixed use of labels and language between anchor institutions, social value, community wealth building, and so on. But saying all of that, I think what there was in common, probably signified by the level of engagement we had with that session with the Health Foundation, was an appetite and an interest to find out more, learn more, understand more, and think about how collectively we could progress this agenda. So we started off with a phase of, I guess, kind of socialising the ideas and focusing attention through that Health Foundation workshop on the concept of anchor institutions, and trying to socialise and get a bit of a shared understanding about what it means to be an anchor and what the potential could be in Dorset to go further faster. So we've used the Health Foundation's 5 pillars for explaining and trying to articulate what it means to be an anchor institution. And they talk about purchasing more locally for social benefit, using buildings and spaces, so our estates, to support communities, working more closely with local partners as a bit of a cross-cutting theme across the other 4 pillars, which are widening access to quality work and reducing environmental impact. And off the back of the session with the Health Foundation, we kind of socialised that ambition to go further, faster through developing a Dorset anchor institution network, bringing individual anchors, individual organisations together. And we shared a draft anchor institution charter to try and put some of that thinking and some of those aspirations down on paper. And at the tail end of last year, we had a series of meetings and one-to-ones with some of the organisations that had expressed an interest in joining. I think in terms of what we're aiming to do through that network, I think the headline for me is it's about creating a space for organisations to support each other to try and develop their understanding and their impact of what they're already doing and what they can do to go further and faster together as anchor institutions. So we're trying to convene and support different organisations around this agenda. We're trying to share and learn information about what it means to be an anchor institution and kind of pockets or examples of good practice from Dorset and beyond between partners, and thinking about the future where we'd like to move. That agenda to is trying to agree on areas or common ground for action on developing some of this work further. And as Paul said, it's supported through the ICS Health Inequalities programme with some resource and some facilitation. What we heard back, just a few messages I wanted to highlight to the board from that initial or from those initial rounds of engagement. We heard that language and shared understanding matters. So I think we're still working on developing our narrative on what the value and what the purpose of an anchor institution network for Dorset can be. We heard very clearly, don't reinvent the wheel, go where the energy is. So rather than replicating or risking knocking off course good work that's already happening and is well established elsewhere, focus on the opportunities or the gaps in this agenda. And we also heard very clearly that it's easy to get lost in the breadth of possibility, thinking about those 5 themes that the Health Foundation position as kind of headlines, I suppose, for the potential of anchor institutions. It's very easy to get lost in the depth of possibility. So organisations that have been involved in the network so far have said that we should focus, or have said very clearly that we should focus on where there's ambition and energy and where those converge. So I wanted to leave you with our next steps and what we're doing now. So we've been going through a process of looking inwards and outwards, looking within Dorset through some of the partners that are working with us, and also looking beyond Dorset to see what other anchor institutions and other anchor institution networks are doing nationally to try and take some of this work forward. And having done that, I'll share a few headlines with you in a moment. We're looking at sharing some of that to see if there are pockets of good practice that we could grow or collaborate in Dorset. And we're also going through a process of holding up a bit of a mirror to what we're doing in Dorset and what others are doing elsewhere nationally, to then pose the question, how do we compare and how might we be able to stretch ourselves to do better, to go further, faster locally by learning from what others are doing. So my last 3 slides are just drilling into a bit more detail on some of what we've heard back from partners from local Dorset anchor institutions about what they're already doing under some of those headline themes or pillars that the Health Foundation set out. So for widening access to quality work, we heard about how partners are providing access to employment for care leavers, an example we heard about in the previous session from Dorset Council's Pathways to Employment scheme. We heard about, or we're seeing examples of how anchors in Dorset are providing routes into employment for young people. So a great example of that is Dorset County Hospital's offer of 46 Kickstart placements to young people. And how I think 90% of that first cohort have gone on to find a substantive role, either with DCH or with another organisation at the end of their Kickstart scheme. And we've heard a lot about how anchors are supporting staff wellbeing and working to retain their workforce, and also looking at providing inclusive employment for marginalised groups. So as an example of that, UHD, University Hospitals Dorset, work about being around being a disability confident employer, and their commitment to the Armed Forces Covenant that I know other anchors in Dorset have also signed up to. We've heard from Dorset anchors about some of the work they're doing and some of the foundations that they're laying to purchase more locally and for social benefit. So we've heard from NHS partners about how they're looking at working through the national directive to apply minimum 10% weighting social value in their procurements. And we've heard from others like Dorset Council about the work they're doing to understand and support, understand the level of procurement they already do with suppliers based in Dorset, and also what they can do to support other suppliers to work with and supply the council. And then finally, another theme where there's quite a lot of exciting work going on, either already or in the pipeline, is about using buildings and spaces to support communities and the environment. So reducing environmental impact, but also very importantly, supporting biodiversity and delivering environmental benefit. So one example of that we've already heard about today is the Dorset Health Village, Southwarks House, and its equivalent over in the Dolphin Centre, and how that looks at using buildings differently to serve multiple purposes across the system, but also potentially deliver other social value, like potentially increasing visits to the high street and footfall with knock-on benefits for local businesses. That was a very quick canter through. The next step that we'll be sharing with those organisations who've joined the network and with others is to, as I said earlier, hold the mirror up to that and look at what other organisations, other anchors nationally are doing, which goes further and beyond some of what we're already seeing in Dorset. And that is my last slide. Thank you, Chair.
Thanks, Rupert. And a question for members today. What is it you would like, apart from sharing a lot of this information within their own organisations? So again, there might be opportunities and suggestions and ideas coming forward. That you met, there is a network already. So what are you asking for? And I will just ask Patricia to step in whilst you just have a quick think to see if there's anything you'd particularly like board members to do apart from share. Patricia, hi there.
Sorry, I was just trying to wait for the air ambulance to go past because you can hear it in my office. So what I was going to suggest is that when we start to think about the areas that we might want to coalesce around, I absolutely understand the rationale of building on what we're already doing. But when Sam has got some reasonable flesh on the framework of the integrated care strategy, if we accept that only 20%, just over 20% of a person's wellbeing is actually about health interventions, the rest is about the broader determinants, then I think what comes out of that co-production exercise with communities around what the strategy needs to focus on will then give us an indication of where we need the anchor principles to really build on, because that's where the partnership really comes into its own around the wider determinants and how we can all, whether it's health or other organisations, coalesce around some of those core pieces of work that come out of the strategy, which will enable us to use all of our resources collectively, and it will also mean that we'll get more pace underneath them if we're focusing on those things that we know are important. Does that make sense?
That made sense to me, and I'm not an expert, but that did make sense. And a lot of the information that Rupert put in there, one can see that how it can spread. Yeah. But as you're saying, let it spread in a way that's going to make the most of it.
Yeah. Thanks, Rupert. to you and Paul. That was great. Thank you.
Really good. Thanks, Rupert and Paul. Rupert, anything you'd like to finally share?
No, just to say thanks, Patricia. That does make a lot of sense. I think in terms of the ask of the board, I think it would be to go through a similar process in terms of getting the board's perspective. If we could share some of the work that I've mentioned we'll be doing to wrap all of this up with board members to see what resonates with them, where they see the potential from that whole breadth of what we could be doing, where we could be coalescing.
Brilliant. So we'll bring it back, but in the right timeline that will make most effect for your point, Patricia. Paul, hi there.
Thank you, Chair, and thanks, Rupert, again for that and Patricia's comment. Just a thought, I get the idea of waiting to see what the sort of system priorities shape up to be. That makes a lot of sense. I think we could probably anticipate that for some, the economy is an issue, and that sort of theme of work of trying to keep some of the business local so that the money circles around local businesses would seem to me a fairly safe bet, but not that we should prejudge. But I was struck in the report that underpins Rupert's slides, some of the stat that really leapt out for me is work they'd done in Preston, where they had looked at the total spending across six of their six major anchor institutions, and they'd managed to increase the spend to local suppliers from just 5% to 18% over a 3-year period, which equated to bringing in an additional 75 million into the local economy, which seems to me the kind of ambition that would be great to hear the board and other partners sign up to.
That is substantial, isn't it? Forbes.
Thank you. It's really just a general comment about anchor institutions. Listening to the two presentations this afternoon, in particular the latter one, Rupert, it's been really helpful to see some clarity, if you like, around the opportunities that exist with anchor institutions. And I think you said at the start of your presentation that anchor institutions really means different things to different people. And I just wonder how we improve our knowledge and understanding, our collective knowledge and understanding, which your presentation has absolutely done today. But that's the first time I've seen that, and I can think of many groups who would benefit from the sharing of that information. And then they will start thinking about the opportunities, both within health and local authorities, but beyond that, really, that might exist.
Yeah. Really good point. Thanks, Forbes. And I think we've still got Kirsty with us, who comms is really important on that one, isn't it? At the right time and the right direction and the right networks. But I'll leave that with the three of you. Patricia, is that a hand up or? Yeah,
it is. I was just thinking about. Yeah, I think I agree with what Forbes said, but I think we as a ICS need to agree on what we see as our definition. Oh, sorry, something's just flown through my window. What we see as our definition of anchor, so we can all sign up to that. And around the things that we might want to focus on in terms of the strategy, absolutely support that point, Paul, about local business and local procurement, keeping people in jobs in their supply chain. But what I also recognise is that even when we do that, wages in some businesses in Dorset are so low that doesn't necessarily make the difference. So I think there's something about us focusing on employment, because we know that one of the causes of deprivation is household wealth and people's ability to earn a reasonable wage, and the public sector can help with some of that. The work that everyone's doing on local procurement, the stuff that we might do in terms of the wider system estate strategy work that we'll be starting again next year, to be clear that health in particular can contribute to local plans around affordable housing by using its estate differently, that keeps young people in Dorset. And what we might do around environmental sustainability, not just because it contributes to the health agenda, but for quite a long period of time, as we double run different solutions, it will create employment opportunities.
Thanks, Patricia. John.
In fairness, I think Patricia's covered it. It's that point about the double whammy benefit of the getting spend into the economy. Just in terms of Paul's numbers, of course, as we all know, it's not just the spend itself; it's the economic multiplier of that, because clearly that money then gets spent in the local economy, paying local people. And I agree absolutely what Patricia said. And of course, this is what we look at when we have a look at the economic strategy side of things, is around needing to raise the level of pay and skill and so on in Dorset economy. That's the real challenge. And again, I think through intelligent use of the Social Value Act opportunities that we've got, we'll probably do that. But I'm sure Paul will come back to this as we discuss the matter further. But it is a real potential for a double whammy on this, without doubt.
Brilliant. Once again, thank you very much, Paul and Rupert. Really, really good stuff. It's feeling like there's a really sound basis for moving forward, and so look forward to hearing back from you. Okay, I'm now going to move on to I'm afraid we are overrunning, but the Better Care Fund is a really important agenda item, so I hope as many people can stay on as possible. There is a presentation which Sarah Sewell, I hope she's still with us, is doing with her colleague Kate.
Good afternoon.
And there is, as Councillor Peter Wolf said, a very detailed report, which I think he was asking for feedback once you properly digested it and heard from Sarah and Kate, and he doesn't mind being emailed after the event at all. So over to you two.
Okay. Good afternoon. I'll just share my screen. We've got a presentation. Bear with me. Oh, there we go. Okay, can you see that?
Yeah.
Yeah, brilliant. Sorry, I can't see you now. I'm showing my screen, so please shout out. Back in January, we committed to providing an update on progress of the BCF funded services and performances against the metrics and some of the finance measures as well. So we've got here a presentation that Kate and I will take you through. So just by way of introduction, I'm Sarah Sewell, one of the strategic commissioning leads in the Adult Social Care Commissioning team. Kate, would you like to introduce yourself?
Yes, hello everybody. I'm Kate Calvert and I'm the Deputy Director for Primary and Community Care at Dorset CCG and have the Better Care Fund within my portfolio.
Thanks, Kate. So you have the covering report and then an Appendix 1, which is the sort of the main body of the report. So just in terms of recommendations, what we've outlined in the report are those recommendations, which are for you to review the contents of the report and confirm that whether it meets the level of detail that you're expecting, and also to please identify any specific measures in addition to those that we've set out, which would help to demonstrate improved outcomes for Dorset. So within the report, there's quite a bit of information, finance and performance information that relates to our performance against the BCF set metrics, to services and contracts that support the mandatory BCF performance outcomes, and those are improved outcomes for those being discharged from hospital, and also for those managing health conditions at home. Also key funding streams. And in addition, we have included in the report some of those key links, so reflecting on some of the conversation back in January, those kind of key links between the purpose of the BCF and the priorities of the Health and Wellbeing Board strategy, so trying to sort of pull out those key links. So just to kind of start off, a useful summary of the vision of the BCF is shown in this infographic, and there's a bit more detail on page 3 of Appendix 1, but I thought it was a useful sort of image to show that depicts the types of sectors that are supported through the BCF funding and how they relate through to the health and wellbeing strategy. Oops, sorry, bear with me. So moving from sort of the starting position of the BCF, it aims to move from sort of the left of this screen with integration of health and social care services moving across to the right, so that individuals can access and receive the care and support that they need in a timely manner closer to home. So we've got there in that image, you've got the individuals and the communities at the heart, accessing those preventative approaches first before the more formal care and support is required. So that BCF approach is really striving to enable the coordination of health and social care services around the individuals, and we hope that vision obviously will resonate through the health and wellbeing strategy. So there's just a few sort of statements there from the person direction as to we're wanting to move from that kind of having to tell my story multiple times and waiting for commissioners to argue about who pays, to that more sort of involved approach of having that having a completed integrated care plan, receiving care close to home. Actually, I haven't been to hospital for ages, and feeling that I can be supported to manage my conditions and live independently. So building on that slide then, this is just an example that I've lifted from section 2 of the report. And what I've done here is just shown those kind of 3 health and wellbeing strategy priorities and linked them to the mandatory outcomes and conditions, the mandatory conditions and the outcomes from the BCF. So it's not a sort of a fully exhaustive list, but I've just picked out a few key ones. So with empowering communities, we support, the BCF is sort of supporting and working with those sort of within those health and wellbeing strategies through the investment in NHS community services, which is helping people to manage their health conditions at home. We've got maintaining independent streams, which include assistive technology, the Dorset Accessible Homes service, which is how we allocate the Disabled Facilities Grant. We have our Dorset Integrated Equipment Service. We have occupational health support and district nursing capacity and carers support, which we could align quite sort of neatly, if you like, to that empowering communities priority. So then moving on to the second priority around healthy lives. We have, through the BCF mandatory conditions and outcomes, we have those improving outcomes for those being discharged from hospital. So that's really supporting that promotion of healthy lives and supporting preventative approaches. So examples of those sorts of services available through the BCF there is our reablement service, the integrated crisis and rapid response service, mental health and dementia support. And then finally, on the priorities, the support and challenge priority of the board, and we have those integrated areas of some health and social care around supporting prevention and enabling independent living. And so we have our integrated community equipment service, which is the one true pooled budget of the BCF at the moment, and also the Dorset Accessible Home Service, which both can be accessed by health and social care professionals to support people. Just in terms of the mandatory metrics that we report on, so we have the 5 health and care metrics. The first 3, avoidable admissions, length of stay and discharge to normal place of residence, are CCG-led metrics, which Kate's going to just take you through in a moment. And then we have residential admissions and reablement, which I'll then pick up afterwards. So I'll just hand over to Kate.
Thanks, Sarah. Okay, so the first metric we have is the unplanned hospitalisation for chronic ambulatory care sensitive conditions. So this is a new metric that's been introduced this year and effectively is an indicator of how well our health and care system is managing long-term or chronic conditions in the community. You'll see that what we've done is used locally produced data to broken down at a geographical level to try and show a trend over time. The national data set is only produced annually and it's age and sex standardised, which we can't do at a local level, but it does give you an idea of the numbers that are in this metric. So it's really difficult, and I know that members will have questions, I'm sure, about the variation across the different localities. We'd need to do an in-depth analysis to really be able to understand that variation. But I guess, you know, as we've talked about earlier in this call, just the pressures of COVID, we've still got the pandemic, it's impacting on our workforce, and we've just had, you know, unprecedented levels of demand across the system, but particularly in primary care. And it is our primary and community care services that really impact on this metric. Next slide, please, Sarah. Okay, the next slide, of course, we've always monitored our length of stay. So we look at longer than 14 days, but also 21 days. With both these measures, it's really important to note that they capture all those within hospitals, so they don't differentiate between those that no longer need to reside and those that do. Once again, we've used locally produced data just because that's more timely, so we can have a bit more of an up-to-date focus and monitoring on the performance. We've equally broken it down geographically, and the variation, of course, will be multifactorial, and it's likely to include, you know, the challenges that we've had in the care market to support those people at home. Next slide, please. So the metric that we have, as you can see, at the end of Q3, we were slightly above the planned target. However, at the end of December, you know, the position had deteriorated. Given the pressures, though, that we've had across the system, I don't think this should be a surprise to partners. And it certainly aligns to the number of those that no longer need to reside in hospital. And everyone collectively across the system, both in health and care, are working really hard to address that. Next slide, please. The final health metric that we report on is the discharge to normal place of residence. And actually, I think this is a good piece of news in the sense that, or in the fact that actually the target for this year in our plan was 91.6%. And at the end of Q3, we recorded 91.5%. So we are trying to actually get people to where they reside normally. Thanks, Sarah.
Okay.
I'll hand it back to you.
Thank you. Thanks, Kate. So I'll just take you through the two council-led metrics. So the first one here, and there's quite a bit of detail on this one, and that's from page 9 of Appendix 1 of the report, is the residential admissions. So this measures the long-term support needs of older people met by admission to a care home per 100,000 of the population. So the total spend from the BCF is just over 61 million, and we're looking for the lower the rate of admission, the better our performance, so people are remaining at home and independent for longer. You can see on the graph there, we've got the Dorset Council kind of whole area average going across the middle of the graph in the green, and our planned rate that we were sort of heading for, the blue above, and then we've broken it down into the local area so you can see the performance at that local level. So I've just listed the headlines there. So Q3 performance is better than the plan, and all three comparator rates from last year. Dorset's England rating is 69, so that sits us towards the bottom of the middle area of the performance table. However, given Dorset's older than an average population, it's unlikely to move sort of to the top of that performance table, but obviously there's always room for improvement. In terms of locality, sort of how that's playing out in localities, so to speak. So people in West Dorset and Weymouth and Portland are more likely to need and to be placed in residential care when compared to the whole Dorset Council area. However, West Dorset does remain below the planned targets. The Weymouth and Portland higher rate for permanent admissions than other areas is consistent with the data that we saw in Q1 and 2, and we will be doing some further monitoring to determine actually all of those factors at play. So whilst the relative higher deprivation may be playing a factor, there'll be other issues and factors at play that we need to look into a bit more before we're able to sort of give any further information on that. And I suppose just referencing on the point that Kate made on the last metric there for the health-led ones, whilst performance is improving, we have been challenged in this area due to the sort of ongoing pressures linked to the home care market, and like other areas of the country, particularly maintaining discharge from hospitals has been a challenge, and that has led to an increase in the need to make more interim placements into care, which could obviously then lead on to those longer term placements. So whilst performance is better than we planned, we could have still improved, and we'll strive to improve that England position. The next metric just to update on is reablement. So again, there's quite a bit of information on page 11 from the report, but this measures the proportion of older people who are still at home 91 days after discharge from hospital into reablement services, and we've got an investment of just under £3.5 million from the BCF into the reablement services. Again, the graph is a similar layout to the one that I've just explained. I've got the headlines for you there. So Q3 performance, we're actually currently sort of as planned. Our average rate is at sort of just under 77%, and the localities ratings are ranging from 74% in North Dorset up to just under 80% in Weymouth and Portland. Our ranked position across England is 94 out of 145. Success rates are lowest for people in North Dorset, but highest for people in Weymouth, Portland and Purbeck. And again, we've got further sort of analysis to do to really get into the detail of that and understand what's at play there. We have been measuring and monitoring performance closely, and we were concerned that we would see a performance drop due to the change in the hospital discharge policy at the end of 2020. That's because essentially that change saw people being discharged from hospital much earlier in their recovery, therefore potentially increasing numbers that would be readmitted. But actually the reablement service have managed to continue to support that recovery at home. So whilst we'll continue to closely monitor that and work with the reablement service to seek the improvements that we can need to further improve that, it hasn't headed the way that we were concerned it might do. It should be said that the capacity within the reablement service isn't meeting all of the system demand, so we have got more work to do in that area. And in terms of sort of improving performance, at present the reablement service contract doesn't employ therapy support, and that would obviously enhance that offer and support people to remain at home for longer. In addition, just to note that the reablement service is also holding a number of vacancies as it's unable to recruit. Again, that's in line with the wider home care challenges of that workforce sector at the moment. So we could see further improvements there with some more focused work with the provider. Just moving on to the other schemes within the BCF. So in terms of the mandatory outcomes, the improving outcomes of people being discharged from hospital and supporting people to manage health conditions at home, we can kind of evidence those with these contracts that we've just given examples of here. So section 4 of the report is where all of the more detailed information is, but I just wanted to just share the headlines with you. So we've got the Disabled Facilities Grant, which is through the Dorset Accessible Home Service, a budget of just over £4 million there, and that's supporting adaptations that enable people to remain at home, so from stair lifts to sort of extensions to homes, ramps and handrails, so quite a range of equipment there. The first 6 months of 21-22, we saw just over 470 adaptations to homes that were completed, and obviously we can update you on that when we bring the next report back. Moving on to the Integrated Community Equipment Service. So this is our true pooled budget. BCP are the lead commissioner, and ourselves and obviously the CCG are partners to that service. So the Dorset contributions 1.23 million, and that service provides a range of equipment from small to complex equipment. So that's from your sort of your walking frames right to sort of big ceiling tracked hoists that are providing and enabling people to remain at home. It's quite a lot of activity goes through this service. So you can see there up to December, more than 6,000 items of equipment were issued through that service. And then finally, this is the service that Councillor Wharf referenced before he left us earlier. So our assistive tech and equipment contract. So this is equipment that has a live monitoring element to it, so it will trigger a response if it's activated. So that's a care line, a falls detector, GPS tracker. So whilst the contract value is small in comparison to the others listed there, as Councillor Wharf referenced, there's quite a lot of innovative work going on that is really a great prevention offer. So we're really keen to sort of show some of that work off. So at the end of the presentation, we'll just pause and just confirm whether or not that's something that you'd like us to come back with at a later date. And then the final area just to sort of flag through is the carers. So you'll know that unpaid carers have a pivotal role in preventing the need for more formal and long-term care and support. And we have just over £1 million worth of funding from the BCF that's enabling a number of different support services and contracts to be in place. And that ranges from information, advice and guidance to specific sort of support for carers who are living or supporting someone with a mental health illness. We have the council's employed carers caseworkers, and then we have a range of other offers such as the short services. We've got the local support at GP practice level, that's sort of signposting and supporting carers in their community. Then we've got befriending training and wellbeing sessions that include counselling. So just in terms of the performance headlines, despite for the first one that we've got here, the proportion of people that receive self-directed support, despite our performance percentage being sort of 98%, our rank is 110, which appears poor, but that's because many authorities have achieved 100% for this indicator. The flip side for that is we've got a lot of work to do on our direct payments. Our performance here is poor, and we've noted that, and we've already have some work in train. It's a priority area for us to improve direct payments and how they're offered. So we've got funding allocated via direct payments to carers is just 10% of the existing budget. So that is, as I say, that's a key area to improve upon. And like I say, we have that work in train across all of the care groups, so not just how we allocate how carers can access direct payments, but all of our care groups. So that is something that we hope to see an improvement into the next financial year. So just in summary, so we believe the VCF investment is making a difference to individuals' lives. We are seeing those improved outcomes through those sort of examples there, and we have identified areas for improvement, investigation and ongoing monitoring. We are due to bring back a further update to you in November, and it's just to kind of leave a few questions in terms of, would you like us to bring the assistive tech work back to the board, and did we get those have we sort of met the recommendations by providing the right level of detail that you were hoping for, and is there anything specific that you'd like sort of brought back or in addition?
Thank you both, and thank you for being so patient on coming in at the end of the meeting. There is a huge amount in the report. If members want to either raise their hands or put their reactions to the questions in the chat bar, I know Sarah and Kate will have a look after the meeting or now. Claire's got a hand up. I would say let's have a conversation about the assisted tech issue outside of the meeting, if that's all right, when with Peter. And as Peter said, anyone feedback, anything that might feel they have a question about after the meeting via email, either to Sarah, Kate, or to Peter or Lesley. So Claire, over to you.
Thank you. Just a question really, and really welcome seeing the report, and know we have performance board reports coming through. At the last board meeting, we talked about opportunities to think through expanding the groups of people that are supported through the Better Care Fund, or with a greater focus perhaps on children and young people, and avoiding hospital admissions, and also through the transitions group, so young people that are moving through from children's services into adult services across the system. I was just wondering what's the process, or where's the opportunity to really think through about what the priority work programs are for the Better Care Fund, and how do we get involved?
Should I go?
Yeah, sure.
Oh, yeah, I mean, we can pick up a conversation about that, Claire. We recognise we've got a lot of work to do with the Better Care Fund. COVID's obviously been a distraction to this, but there is opportunity to look at how we use the funding and how we might prioritise funding streams in the future. So there's lots of opportunities there to pick that up. So we could take that offline if that's okay.
Okay.
Also, just to come in, sorry, Rebecca, just to come in, Claire, we certainly would support, that view of trying to widen the Better Care Fund, and we've had conversations strategically about where we take this forward. It is a great vehicle, I think. When we talked earlier about integration and getting more integrated, then this is a vehicle for us to do that. And I think if we're really going to make a difference, then we need to do more of this, and really strategically think about how we pull our investment together that will make a difference for people of Dorset.
Sound okay, Claire? So
yeah, great.
Get
Thank
the
you.
question and move it forward. Sam, you've really well done, and put your remarks in the chat bar. If everyone else has got some remarks, that would be good. Sam, did you want to? Yeah.
I was just going to really support Kate's comment there, going back to Simon Raw's observation about having a proper conversation about what integration means from the perspective of the people using services. There is there's a whole strand to the ICP strategy development that should be about Claire's point. How do we identify what the priorities should be, and that might be different depending on where in Dorset you live. So yeah, I think we'd love to kind of take that under the wing of the strategy development. Obviously, it's not the whole of the process, but I think starting that conversation would be really, really important. So thank you.
Good. Great. Thank you very much, Sarah and Kate. And yeah, very detailed. And we look forward to an update. We'll talk about that probably between board meetings with Peter and Lesley. And thank you very, very much for being so patient and for doing that presentation for us. Thank you.
Thank you.
Right, everybody. There's just a few formalities to go through. Forward plan is in your pack. Paul and I and George go through the forward plan. So we will take from the meeting today what needs to be added in. But if you have anything that you would like to put on, it would be really helpful to email George if you can, or Paul or me, because suddenly some things pop onto it and we think, is this really the right place for the discussion, or what's this about? So if you email us as well, that would be really helpful. Number 12, there's no urgent items. And there's no exempt business under number 13, and number 14 is date of next meeting, which I believe is in July, but I can't be certain. We'll make sure you've all got the dates in your diary. We will be continuing virtually if we can. There's a paper just to get through one of the audit processes. But I feel that a meeting in person might be quite good for some of the development sessions. So we'll talk about that after this meeting. So thanks everybody for your time. Apologies about the extended meeting, but there was a huge amount in it today. So farewell and goodbye. Till next time.